Thanks so much, Sharon. It's a pleasure to be here, and thank you for inviting me back today. I'm going to be talking, as you mentioned, about rare ovarian cancers. And while I'm the section head of ovarian cancer at Memorial Sloan Kettering Cancer Center, much of my research has really focused on these rare cancers. And that's in part because many of these patients are excluded from our major ovarian cancer clinical trials. And we want to make sure that our patients with rare ovarian cancer are not left behind and that we're working just as hard to find novel opportunities for our patients that have these less common cancers. And I love this title that Brunci recommended for the talk today, Pathbreaking Advances in Rare Ovarian Cancers, because I'm happy to say that I think we really will be talking about some pathbreaking advances here. I will be talking about investigational use of drugs today, as well as ongoing clinical trials. I want to really bring you guys the latest and greatest and some groundbreaking news. So I'm going to be talking mostly about low-grade serous ovarian cancer. So low-grade serous ovarian cancer is a rarer form of ovarian cancer that accounts for less than 10% of newly diagnosed ovarian cancer cases. And so the median age of diagnosis for our patients with low-grade serous ovarian cancer is lower, 40 to 50 years. And this is really because there's two major ages where patients are diagnosed with this cancer. There's a cohort of women who are diagnosed very young in their 20s or 30s with this disease. And then another cohort of women who are diagnosed later in life, generally in their 60s or 70s. Now, traditionally, when we talk about low-grade serous ovarian cancer, the first thing that we oftentimes say about it is that it is less responsive to chemotherapy than high-grade serous ovarian cancer. So when women with advanced ovarian cancer who have high-grade serous ovarian cancer are first treated with that carboplatin and Taxol chemotherapy, about 80 to 90% of women will have a significant reduction in their cancer with that chemo, while only about 23% of women with low-grade serous ovarian cancer will have a significant reduction. Now, I do want to mention that that doesn't mean that chemo doesn't have any activity in low-grade serous ovarian cancer. It does, but it's less effective than it is in high-grade serous ovarian cancer. So this really led us to try to find new ways to treat this disease. About 10 years ago, unfortunately, when we'd meet women with low-grade serous ovarian cancer, we would say that we expect lower response rates to chemo, but we didn't really have anything different to offer these women than the same treatments that we treat women with high-grade serous ovarian cancer with. However, we did find that patients with low-grade serous ovarian cancer, when we looked at the DNA inside of their tumors, were more likely to have alterations in a pathway called the MAP kinase pathway. Now, the MAP kinase pathway is a cell signaling pathway that's found inside of cells. And in cancer cells, this pathway can be upregulated, meaning that it stays turned on. And when that pathway is turned on, the cells keep replicating and dividing, and they don't stop like how a normal cell would. And this leads to tumor formation in cancer. And so a drug that could potentially target this pathway is called a MEK inhibitor. And one of the first clinical trials ever looking at the use of MEK inhibitors in women with low-grade serous ovarian cancer used a drug called selumetinib. And so we enrolled to that study here at Sloan Kettering. And one of our patients who went on to this study in 2009 had had many years of prior chemotherapy with poor responses and had been through multiple surgeries. She then entered onto this clinical trial with this pill therapy called selumetinib, a single-agent MEK inhibitor, and actually had what we call a complete response, meaning that her cancer became invisible on a CAT scan. And the really amazing thing was that once she entered into this complete response, she remained in a complete response. And she's actually been on this treatment for 15 years without any signs of cancer. Which is really tremendous and something that we hadn't really seen in low-grade serous ovarian cancer before these first trials. Similarly, a patient at MD Anderson Cancer Center who enrolled to the same study also spent many, many years on this same treatment. And interestingly, during the course of her life, she held treatment at multiple times for other life events, during which time the cancer would start to grow back. But then as soon as she started her pill therapy again, it regressed, showing that our patients with low-grade serous ovarian cancer could in some cases have incredibly prolonged responses to these treatments. Of course, though, it doesn't work for everybody. And so we wanted to dig deeper to find out how we could predict for which women would be most likely to respond to this type of therapy. So for our patient who had been a long-term responder, we looked back at her original tumor tissue after her informed consent and found a deletion in the MAP2K1 gene. We then actually replicated that gene mutation in cell culture and actually then created a mouse model with that same mutation and showed that it sensitized to treatment with this drug. This is also a 3D crystallography showing what that mutation looks like inside the cell. And this really goes back to what Dr. Blank was saying about how incredibly important it is for our patients who make that huge sacrifice to participate in clinical trials and spend a lot of time and effort participating in these studies. How much we can learn from each individual patient that does that, and how it can really help the future outcomes of other patients. We subsequently looked at our population of patients who'd been treated at Sloan Kettering over many years with low-grade serous ovarian cancer. And we found that more than half of our patients have some type of alteration affecting this pathway, the MAP kinase pathway, whether it be a KRAS or NRAS or BRAF mutation. We characterized what the mutation was in over 100 patients. And then we also looked at other demographic signs and how they were correlated with this mutation status. We found that patients who were older at time of diagnosis were more likely to have a KRAS mutation or other MAP kinase alteration. And we also found that those patients that had a MAP kinase alteration were more likely to be sensitive to chemotherapy, helping us to give patients more informed information about how likely they may be to respond to a particular treatment. Two major phase 3 studies were opened that looked at the use of these single-agent MEK inhibitors in patients with recurrent low-grade serous ovarian cancer. One of these studies was led by my colleague, Dr. Gershenson at MD Anderson Cancer Center, called GOG 281, which looked at the use of a single-agent MEK inhibitor called trametinib versus patients being treated with chemotherapy or endocrine therapy. And another study called the MILO study that looked at patients treated with a different MEK inhibitor, binimetinib, or chemotherapy. And both of these studies showed good response rates for patients treated with the MEK inhibitor. In the case of the trametinib study, the response rate was 26%. In the case of the binimetinib study, the response rate was 16%. And then with longer subsequent follow-up, the response rate was actually 24% on an updated analysis we presented in 2020. And so this was giving us a new option for our patients with recurrent low-grade serous ovarian cancer to be able to offer them this pill therapy called a MEK inhibitor for treatment of recurrent disease. So although these response rates of 24, 26% were higher than what we had seen before with chemotherapy or other drugs in the recurrent setting, we still wanted to find ways to further improve that response rate, of course, because 24% is a good response rate, but we can do better, and we definitely want to do better. So we want to find ways to enhance that response rate. So again, we dug deeper into the information available from our patients who had participated in these clinical trials to try to learn as much as possible. And really be able to benefit from that information that is so important that we can get in this prospective nature from clinical trials. So this was a study we subsequently did looking at the archival tissue that patients had contributed to the binimetinib study before enrolling onto that clinical trial. And this study found that in the patients whose tumor had a MAP kinase alteration who were treated with binimetinib, the response rate to binimetinib was actually 41% versus 13% in those patients who did not have a MAP kinase alteration identified in their tumor. So what this told us is that those patients that were found to have this alteration in their tumor had higher response rates to treatment with this MEK inhibitor. And really, we wanted to work on that in two different ways. We said, okay, well, that's great. So we know that the response rate's higher in patients with this mutation, and 41% is a good response rate. But how can we make that even better? How can we add to this MEK inhibitor to make it more active in those patients that have this mutation identified in their tumors? And then just as importantly, what about those patients that don't have the mutation in their tumor? What can we do to enhance the activity of these targeted therapies in those patients? So this led us to look for new novel drug combinations. And so this brings us to a combination that's showing really exciting activity right now in low-grade serous ovarian cancer. And these drugs are called avutometinib and defactinib. These drugs are both investigational and are not FDA approved. Okay, they're only in clinical trials. Avutometinib is a first-in-class oral RAF/MEK clamp that potently inhibits MEK kinase activity while also blocking compensatory reactivation. So when patients have one of these pathways that's upregulated in their cancer, sometimes if you block the pathway, there's a parallel pathway that can then overcome that. And so one of our ways to try to prevent that is to target multiple pathways at once to try to prevent this compensatory upregulation. And then defactinib is a selective inhibitor of FAK that helps to mediate resistance to anti-cancer drugs. Avutometinib and defactinib are both pills, and they're both what we would call targeted therapies. So there's actually still an ongoing phase 1 study in the UK of this combination of avutometinib and defactinib that showed a really good response rate of 42% and a median duration of response of 26.9 months. So patients were staying on the treatment for a really long time in patients with recurrent cancer. And this study enrolled patients with low-grade serous ovarian cancer as well as other types of cancer like lung cancer. So specifically the results seen in patients with low-grade serous ovarian cancer in that phase 1 study led to FDA breakthrough therapy designation of this drug combination and is the rationale for an ongoing phase 2 study looking at this drug combination in women with recurrent low-grade serous ovarian cancer. So that study is called the RAMP 201 study, and it's open in the United States under the name GOG 3052 and in Europe under the name NGOT OV60. It's an international study. And this study has now completed accrual, but the patients remain on treatment. And so this study enrolled women with recurrent low-grade serous ovarian cancer. In the first part of the study, women were randomized to either receive the avutometinib as a single agent drug or the avutometinib in combination with the defactinib. And these are pills. The avutometinib is taken twice a week, 3 weeks on, 1 week off. The defactinib is taken twice a day, 3 weeks on, 1 week off. And so I had the opportunity to present some of the initial results from this ongoing study at the IGCS conference in Korea this past year, which showed really impressive results for the patients who were treated in part A of this study. So we have follow-up from the patients in the first cohort treated on this study. We're still following the patients that have been treated in the subsequent cohorts and getting more follow-up information on those patients before the final results of the study can be presented. But this is a waterfall plot. So each one of these columns on this plot represents an individual patient and shows how much tumor reduction they had while they were on the clinical trial. And so, for example, this patient all the way on the right here, this blue bar all the way on the right, they had 100% reduction. So that's what we would call a complete response. And we love when that happens, of course. So this study showed overall a response rate of 45% for the cohort overall, and specifically in those patients whose tumor had a KRAS mutation, a 60% response rate. In those patients that were KRAS wild type, a 29% response rate. And overall, tumor reduction was seen in 86% of the patients with recurrent low-grade serous ovarian cancer who were treated in this combination. So I was just so excited to present these results, and I can't stop talking about them. But we also looked specifically at those patients who had had a lot of prior lines of therapy versus those patients who had not had many prior lines of therapy. Because like when we talk about chemotherapy, we often talk about how patients develop resistance over time. And unfortunately, it's oftentimes the chemos we use in the beginning that our patients are most sensitive to. And when we've been through more lines of therapy, it can become more difficult to attain a response to that chemotherapy. But really interestingly here, whether the patients had had less than 4 prior lines of therapy before going on study or more than 4 prior lines of therapy before going on study, the response rates were basically the same. So the response rate was 45% in those people that had less than 4 prior lines of therapy, and it was 44.4% in those patients that had 4 or more prior lines of therapy before they went on the study, because patients were allowed to have unlimited number of prior lines of therapy before they went on the study. So some of these women had been through many different treatments before they enrolled to the study. And so that was, really encouraging to us that even in our what we call really heavily pretreated patients, that we had these really nice response rates seen. So based on those results, there is now a phase 3 study open looking at this combination in women with recurrent low-grade serous ovarian cancer. So this study is just kicking off in the United States and internationally. This study is called RAMP 301. In the United States, it's called GOG 3097. In Europe, it's called NGOT OV81. Studies also open in Australia, also plan to open in Korea. So bringing these drugs across the globe to our patients with recurrent low-grade serous ovarian cancer. And this study will enroll women who have recurrent low-grade serous ovarian cancer and what we call measurable disease. So cancer that can be measured on a CAT scan, that's a nodule that's at least 1 centimeter, or a lymph node that's at least 1.5 centimeters. And then patients on the study are randomized to either this combination of avutometinib and defactinib, or what we call physician's choice of therapy, meaning that the patient and their doctor decide together what type of chemotherapy or endocrine therapy they'd like to be treated with. Now, importantly, and this is something we really pushed for in this study when we were developing this study, the study has crossover, meaning that women who are randomized to receive the standard of care treatment, like chemotherapy or endocrine therapy, have the opportunity to potentially cross over to avutometinib and defactinib if the standard of care treatment does not work for them or stops working for them. So very excited to have that study opening across the globe right now, and hopefully soon we'll be able to offer this to many more of our patients. So, but these drugs, avutometinib and defactinib and MEK-RAF combination therapy, it works more on a molecular pathway than a specific histology. So when we have an active combination, we always ask ourselves, what other types of cancer could this be helpful for? And how else could we help patients with a similar alteration to see this benefit? And so looking at our cancers that we treat that have limited options, another type of rare ovarian cancer is called mesonephric-like ovarian cancer. And so mesonephric cancer is a type of cervical cancer. But then there's mesonephric-like, which is a type of histology that's quite rare, that can be seen as an ovarian cancer or an endometrial cancer or a vaginal cancer or occasionally endometriosis-associated cancer. And these cancers also really have had a paucity of any clinical trial data looking at novel agents. So we generally have treated them with conventional chemotherapy. But we know from prior studies at our institution and other institutions that almost all of the women with mesonephric-like cancer will have a KRAS mutation in their cancer cells. And as we saw in these earlier slides, those patients with low-grade serous ovarian cancer that had a KRAS mutation were the ones that had the highest response rate to this combination therapy. And so this is what we call an oncoplot, looking at tumor tissue from our patients who had mesonephric-like or mesonephric cancer. And the rows at the top represent individual patients, and then the rows on the side represent two alterations that could be seen in the cancer DNA. And almost all of our patients with mesonephric-like cancer have either a KRAS or an NRAS mutation, so some type of mutation affecting the MAP kinase pathway. So based on that information, we developed a phase 2 study of this same combination of drugs in patients with mesonephric or mesonephric-like gynecologic cancer that was advanced metastatic disease or recurrent disease. So it's a small study, 20 patients. But it's enrolled actually really quickly since this is a rare cancer without many clinical trial opportunities. And we're seeing meaningful responses in heavily pretreated patients with mesonephric-like cancer being treated with this combination. And so, more to come on treating that disease, but we definitely want to keep thinking about these rare cancers and trying to bring novel drug combinations to these patients. And then finally, I just wanted to talk about, how clinical trials work and how we can really try to bring the newest and best options to our patients as quick as possible. And also, we want to be able to do it in a way that will be meaningful to people during their lifetime, right? You don't want to wait for a drug development to take 10 or 15 years. If something's looking promising, you want to be able to have the opportunity to receive it in real time. And so one initiative that the FDA has been talking about is something called Project Frontrunner. So Project Frontrunner is an oncology center of excellence initiative to encourage drug sponsors to consider when it may be appropriate to first develop and seek approval of new cancer drugs for advanced or metastatic disease in an earlier clinical setting, rather than the usual approach to develop and seek approval of a new drug for treatment of patients who've received multiple prior lines of therapy. Because generally when we have a new treatment, we start with these clinical trials for patients with recurrent disease who have already had a lot of treatment. But then, these studies we've had looking at the use of targeted therapies in low-grade serous ovarian cancer, my patients will often say to me, well, if these results are looking so promising, why do I have to wait and see if the cancer comes back before I can try a treatment like that? Why aren't you working on options to try to use these novel treatments earlier in the course of my therapy and to see if it will help prevent my cancer from ever recurring? And so taking that into account, we developed a new study that's just opening at Sloan Kettering that looks to see if we can improve outcomes in our patients with advanced low-grade serous ovarian cancer by using these targeted drugs earlier in their disease course. And so this study was developed with a fantastic fellow who I work with, Beryl Manning-Geist, and she came up with the name here of Chameleon, because the study is called Combination Targeted and Hormonal Treatment of Low-Grade Serous Ovarian Cancer in the Upfront Setting. And that's my fellow there, Beryl. She's excellent doctor. And so this study is for patients with advanced low-grade serous ovarian cancer who are newly diagnosed and are not a candidate for primary debulking surgery. So patients who unfortunately have too extensive of cancer that it would not be feasible for them to have a complete gross resection of their disease, or for women who have had a primary resection of their cancer, but it couldn't all be removed, what we call a suboptimal debulking. So women who had a suboptimal debulking and now have at least a centimeter of residual cancer left behind. And for patients that enroll to this study, they're treated with this novel combination of avutometinib and defactinib in combination with a third drug, letrozole, to try to see if that gives significant tumor shrinkage and to see what the long-term outcomes are for these patients. And so I think this will give us really important information about the use of these targeted drugs in earlier line setting for our patients who are generally less sensitive to traditional chemotherapy. And then I just wanted to also mention that in developing all of this research and these clinical trials, something that is so incredibly important is patient advocacy. And we rely on our patients to help us to design clinical trials that will be feasible for our patients and have the right quality of life metrics. And particularly in low-grade serous ovarian cancer, we've worked with the STAR Foundation and with the Ludeman family, who developed something called the ICLC, which is a group of experts in low-grade serous ovarian cancer, who work together to try to develop novel studies for patients with low-grade serous ovarian cancer. So the fantastic members of OVARCOM and STAR and other advocacy groups really help us to make major headway in the development of these clinical trials and really help to further our research so much. And then finally, I just wanted to close because Runci always asks us to include a fun fact about ourselves. And I'm not the funnest person in the world, but I did wear my Hope t-shirt today. And as my fun fact, I wanted to include that I know that one of the key words for today was hope, and I do think that hope is so incredibly important. And I think it's so important that it's what I actually named my daughter. So this is my daughter, Molly Hope, and she's a really great kid. And when I named her, we were it was funny because I told my husband, I was like, I want her to be able to say hope is my middle name, like, because you're never going to lose hope. You're always going to have hope for the future, because no matter what you're facing at the present time, things can always change in the future, and there's always people working towards change. And so I thank you guys so much for your time today, and I'm happy to answer any questions during the panel discussion time. Thank you.